Dr. Donna Willis for the Learning Channel. What you're about to see is a real operation. This type of program is not for everyone. We're about to witness the miracle of birth combined with the technology of modern medicine. Because childbirth can sometimes pose a threat to both mother and baby, a cesarean section can be a safe alternative. Named after Julius Caesar, who according to legend entered the world this way, a cesarean is the delivery of a baby through an incision in the mother's lower abdomen. Joan and Tim Barber's baby is in breech position, and if delivered naturally, would travel down the birth canal feet first. To prevent the baby from getting stuck, Dr. Nancy Cheshire will perform a C-section. Join us as the doctor and the family prepare for the operation.
We have our nursery ready. We've had it ready for several weeks now. We have our crib and our diaper changer. We kind of got that set together. So from the crib to the changer.
Got her rocking chair already in there, so she can rock the baby to sleep.
I had a C-section once before, and that was an unfortunate situation. We lost the child because of a heart problem. When the doctor told me C-section, I said, oh my gosh, major surgery. I cried for days. The baby had been head down almost my whole term of pregnancy, except for these last couple of weeks, and the baby had turned head back up, and would not turn again. And they gave me a couple of weeks just to make sure. It was Nancy Cheshire said probably the baby would not turn, but we wanted to give it maybe the benefit of the doubt that it might, just in case.
With the Barber specifically, the indication for her C-section was that this was a breech baby, a baby who instead of coming head first was coming with the buttocks first. 97% of babies at term will be head down. Only 3% will be in some sort of other position, most commonly a breech, but sometimes sideways in the uterus.
The main thing is the baby. What's the best route we should take for the health of the baby? And it seems to be that the cesarean is what everybody has decided that we need to do.
In a fetus, the head is proportionately bigger than the rest of the body. One can get a situation where the breech delivers through a 7, 8, 9 centimeter dilated cervix. The body delivers to the head, and then the head, which needs a 10 centimeter dilated cervix, can get trapped behind an incompletely dilated cervix. That doesn't usually happen with breeches, but again, one wants to be very careful that you're dealing with a baby who is between about 1,000 grams of weight, about 2.2 pounds, up to about 7 or 8 pounds of weight. If you're outside of those estimated weights, then babies probably ought to be delivered by C-section. And there it is, as big as life.
Yep, very much so.
Okay, so that head's sitting right up under your liver still.
The surgery part was scary for me. I was concerned about her. I was relieved that they knew enough that the baby was not turned correctly, that they were able to do a C-section.
I don't think so.
The procedures that they do now, it's just so much more advanced, the technology is. That
Very much so. Nancy Cheshire has been a wonderful doctor to me. She has my vote of confidence, and that means a lot when you go into, say, major surgery, and I consider that major surgery. You want to be able to feel comfortable and be able to depend on your doctor.
The whole family-centered birth approach that's common now, where the desire is to have women have some sort of support person, either it's the father of the baby or her mom or dad or a sister or whatever, in the delivery room, has clearly extended to cesarean sections. It began more or less with vaginal deliveries, trying to make the birth what it ought to be, which is a family-centered event.
Ms. Barber, I'm Dr. Spielman. We met earlier, and I'm going to go ahead and put that epidural in now. And have you turn on your side and face your husband, curl up in a ball. I'm going to tell you everything I do before I do it. There'll be no surprises, okay? Any questions before we get started?
Yeah.
Okay, so
Most cesarean sections in our hospital, and in fact in the country, are done with what's called a regional anesthetic, so that the woman is numbed from her chest down, providing good pain relief for her during the C-section. But she's awake and talking and involved, and it's very comforting to her to have someone with her that she knows, preferably the father of the baby.
next thing I'm going to do is start putting the epidural needle in place. The skin's pretty anesthetized, and I think you'll just feel some hard pushing back there now.
The anesthesia we're using on Joan is called an epidural. The epidural is administered through a small tube which is inserted between the vertebrae but not through the spinal cord casing. First, Dr. Spielman will position a needle into the correct area, and then a small tube is inserted through the needle. The needle itself is removed, leaving the tube in place during the operation. Should Joan require more pain relief, it can be delivered at any time without interrupting the operation.
You doing all right, Miss Barber?
Okay.
Okay. The needle's in the right place. It didn't take too long, okay? What I'm going to do now is put the tiny little epidural tube in your back. Sometimes when the tube goes in, it tickles a nerve and makes it feel like a little electric feeling running down one of your legs, like if you hit your funny bone in your arm. If that happens, it'll go away very quickly. It doesn't do any damage, okay? There's nothing to be scared about.
There has been an evolution of the way anesthesia has been given for childbirth. Back in the 40s and 50s, just for vaginal delivery, lots of women experienced what's called twilight sleep, where they were given a fairly heavily sedating gas to inhale and really weren't conscious. And again, getting back to some of the family-centered things, there's been a better a progression towards better forms of anesthesia just for childbirth in general, to allow women to experience that without being knocked out or being very sedated. And that's also extended to C-sections, where fewer and fewer are done with a general anesthetic where the woman's asleep during the procedure.
They're getting the operating room ready for you.
Good.
In a little bit, we're going to go on back. Now, the important thing that you do need to understand with epidural when you have a C-section is you feel push, pull, and tug.
Right.
If you feel me pushing on your shoulder, you know I'm doing something. It doesn't hurt, right?
Right.
Okay, so, and I'll tell you that a couple more times just to remind you, it's normal to feel push, pulls, and tug with a C-section, particularly if you've had a C-section before, and around the time that the baby's coming out,
Yes.
you feel extra push, pull, and tug.
Yes.
And we're ready in the back.
The baby is connected to the uterus by the umbilical cord, which is fed by the placenta. The placenta itself is attached to the uterine lining by thread-like roots and contains about a half a cup of fetal blood. The placenta has been responsible for nourishing the baby throughout the pregnancy and will appear to be a plate-like or pancake-like organ. At the time of delivery, it will detach from the uterus and be delivered shortly after the baby. This graphic shows the normal position of a full-term baby. Joan and Tim's baby is in what is called a Frank breech position, meaning that it is rear or buttocks down over the cervix as opposed to feet down, which would be a footling breech. I have 7 layers to go through to deliver the baby. The skin, or derma, which is composed of the outer layer of skin and the fat. The fascia, which is a tough, thin layer that supports the muscle, and the muscle itself, known as the rectus muscles, which are a pair of strap-like muscles that run up and down in the abdomen. The peritoneum is a shiny surface that encases the entire abdominal cavity and also encases the uterus. The uterus itself is a thick muscle, and also the baby is encased in a fluid-filled bag called the amniotic sac. The sac needs to be broken, and at that time we'll see a rush of fluid and the baby can be delivered. When a cesarean section's being planned and going on, the senior surgeon, obstetrician in the delivery room has responsibility really to make sure that all of the processes that are going on with all of the individuals need to be done appropriately. It's important to recognize that this is not an operation that's just a technical feat. This is an operation that ends up with a new member of a family. And so it's real important as much as possible to keep that focus and to pay attention to those things. And frequently, if you do that, then things do tend to flow. The other thing you have to make sure of is that you're dealing with colleagues, either nursing personnel or physician personnel, who keep that as their focus as well. And that's one of the things that the people here do extremely well. Okay, what we're going to be doing here is a C-section through a previous scar, and you can see that scar across here. This is called a Phanencele, and I'm getting ready to start, and I'm going to go right along her previous incision. Joan, we've started, okay? This incision goes through the skin and then goes through the connective tissue. The soft tissue, the kind of the first layer beneath it, is essentially the fat layer. And snap, please. Remember, I don't bovie with the baby in utero. What we'll do is go down through this fatty layer. There's a little bit of other kind of connective tissue in here, and obviously some blood vessels. That's where we want to be there. This incision is called a Phanencele incision, and at least the mythology, if not the truth of it, is that it was developed by a German gynecologist in order to hide his incision for hysterectomies, so that it wouldn't be known by the woman's partner that she was sterile, because that would have made her unacceptable as a wife. And so it's designed to hide her incision. The layer I'm cutting now is called the fascia, and the fascia is the strongest layer. We'll come back and get that with a knife here in just a minute. And the fascia is going to be the layer that I really want to make sure gets reapproximated closely when we close. Okay, can I have pickups with teeth, please, and Mayo scissors? What Wendy's doing is giving me retraction and showing me the spaces I want to go at. This is the fascia. There's usually 2 layers of it. Sometimes with the previous scar, they're kind of healed together, and underneath it you can see the rectus muscles. Have that free tie, please. So just one end of that. What I'm doing now is one of the blood vessels that was bleeding as we went through that layer before, I'm just putting a tie around it so it doesn't continue to bleed. This particular layer, a lot of these would probably clot off and not need to be sutured, but I like to go ahead and suture them as I'm going through them. Okay, 2 cokers, please. The next thing we've got to do is to get the fascia, which invests lays on top of this muscle, basically. We're going to go in sort of a combination of sharply and bluntly dissect it off of the muscle. And I've got a little bit of it here still. There we go. And we're just running our hands up along the middle. Okay, knife, please, ma'am. She's got a little bit of what's called a rectus diastasis, which most pregnant women have, which is where the rectus muscles, which usually they run as a strap up, a pair of straps basically up and down the midline. There we go. That's good.
Did they try to turn around?
I think that's just sort of diffuse oozing at this point, and I'm not seeing anything I could snap there even. So we're going to go ahead and go below and do basically the same thing from the incision down towards the pubic symphysis, which is the top of the pubic bone. And in order to get adequate exposure, you have to go all the way down to the symphysis. And frequently this side will come a little bit easier than the other side. Okay, and that's nice and down. Okay. Yeah, I'm going to go ahead and take this down now.
Can I have a large rich, please?
Yes, just a little bit, and some mayos again, please. Thank you. This is, again, just more of the fascia. Wanted to get out of the way here.
Nice.
Okay. Super. Where was my original hole that I made up here? Okay, now this is the peritoneum. The peritoneum is one of the connective tissue layers that is fairly thin. It lines the entire abdominal cavity. It's nice and smooth and glistening, as you can see here.
Uterus right underneath.
Yeah, this is the uterus, and this is a little bit of adhesion from her previous surgery. Bladder is down in this area. I want to make sure that I don't get into her bladder. May I have the Russians, please? Let's see, that's clearly something I could take.
Good.
Okay. And we're just pulling to increase our exposure here. This is still the bladder that's scarred up a little bit on top of the uterus. And so what I'm doing is trying to get it off the uterus. And this is one of the areas where I worry a whole lot more on a repeat C-section than on a primary C-section. These are blood vessels on the bladder there. And this is just going to all have to come off sharply. Boy, that is really stuck, isn't it?
Yeah, it is, but I mean, it's still.
Do you have a snap, please?
It's a beautiful area. I don't know.
Hold that up for a minute.
Okay, so what we're doing is just, again, trying to make sure that I've got a place where I can make this incision without getting into any structures that I don't want to get into, and I think that's going to be all right. I think that's pretty good. Let's put the bladder blade. What we're going to do now is put this bladder blade and hide the bladder behind it,
Could I have a large rich, please?
and that's done a nice job. Okay, what I'm going to do now is to make the uterine incision. This is what's called a lower uterine incision, or low transverse C-section. I've taken the bladder off and sort of the connective tissue off of the uterus, and this is the uterus here. It's fairly thin in this part. And I'm going to make just a midline incision here, then I'll need the bandage scissors. I'm just going to go across. A little bit of fluid coming out there.
Nice and clear.
Nice thin lower uterine segment. The fluid's clear around the baby. That's great.
That's wonderful.
Sometimes they have to just clear the baby's airway out.
See the sap.
And I'm just, you can see just a little pinhole here, which is fine. And that's fluid, and then I'm going to tear this up a little bit. Okay, take that out for me, please. Okay,
On
nice.
the table.
Let's go ahead and rupture these so I can get
Okay,
a
could I have
great.
Alice, please?
Okay, we're going to have a big splash here. Go ahead. You got the bag of waters there, basically, and that's the fluid that just came out. This is the baby's little butt, and there's a scrotum, some meconium. There are the feet.
Everything but the baby's head's out already.
Getting the hands. Oh, baby lifted great out. That's wonderful. There's this babe. Hey, sweet thing.
Baby's out.
Dad, you want to see? Tim, you want to stand up? You can see your son. Hey, Jacob. He's covered with a white. Good. We knew that. Hope that. He's got nice hair.
He's beautiful.
He's gorgeous. We're just cutting his cord here and sectioning his mouth out. And I'm going to pick him up and let you see him here, okay? He looks great. He's gorgeous. Yeah, he's got hair. He's wiggly here. Just a minute. Take a look here. There he is. Wow, big sneeze.
And the ball.
There you go. I like it when they come out like that. Once I've passed Jacob off to the pediatricians, they're going to have to make a real quick evaluation of how he's doing. One of the biggest problems babies have right after they're born is that they can get very cold. They've gone from a real warm environment to what's really quite a cool operating room. So they'll put the baby under a set of warming lights and keep him warm, and there'll be someone listening to his heartbeat to make sure it's a normal heartbeat and watching his respirations. Okay, what we're doing is collecting cord blood. Every baby needs to have cord blood obtained. He looks great, John and Tim. He looks wonderful.
Now the baby's out, I'm going to tilt you back, okay?
There we go. We're going to tip her out of her left-sided position here. We keep women on their left side during labor and during C-sections to get the uterus off of the blood vessels that come up from the body. Can I have a little bit of irrigation, please? 3365, 7 pounds, 6.5 ounces. Okay, this is the cord. You can perhaps see that there are 3 vessels there. There are 2 arteries and a vein. The arteries carry blood from the baby to the placenta, and what I'm trying to do right now is to deliver the placenta. Placenta is a disc or pancake-like structure that is actually part of the baby's development, and it attaches over a broad surface to the uterus. The fetal, you can breathe now? Good. The fetal blood vessels don't mix in with the maternal, but they run sort of in parallel to each other and exchange nutrients. And this is the placenta coming. And we'll look at that in just a minute. I'm actually going to deliver this uterus here.
What a hit.
He sounds great. Okay, and this is the whole uterus here. This is the top of the uterus. And this is the incision, and this is where the baby just was. This is the lower part of the incision. As you can see, this is a little bloody, and this is very normal at this point. We're going to go ahead and close this incision. Okay, these are big blood vessels that come up,
They put a blue one on the board.
called the uterine blood vessels for obvious reasons. These are veins and arteries, and they're very big compared to what they are when a woman's not pregnant. This is the fallopian tube with the fimbria, and right here would be the opening of the tube. There's the exact same one on the other side. This structure is called the round ligament. And the round ligament is one of the supporting structures of the uterus. May I have the Russian stamp, please? And here's the ovary back here on this side.
He doesn't pay his bill, we'll crash.
Okay, I sure will. The uterus can measure up to as big as 40, 45 centimeters during the late part of pregnancy in order to accommodate the baby. And normally it's about the size of a woman's fist. So it grows from about 2 ounces prior to pregnancy to about 2.5 pounds just for the uterus itself. And now what I'm doing is just closing this layer. The blood vessels to the uterus are not really discrete vessels once they get into the uterine cavity, but they're sort of a network instead of multiple what we call sinuses, and perhaps we'll show you one of those here. But in order to get blood bleeding to stop, you have to pretty much close the uterus. You can't just tie off a vessel or something.
Great.
This is what's called a running lock stitch, and there are lots of different ways people do this. This is the way I do it. This is the way I was taught, and it makes sense to me. What we do is lock this first layer, and what I'm trying to do is not to close the uterus, the lining of the uterus, but just the walls of the uterus together. There we go.
Keep that bladder down.
Yeah. Don't want to close her bladder up into this. Here comes Jacob.
Hi, Mom.
What a fit. Good gracious. Oh.
This part of the surgery just seems to take
How about that?
climax over here. It's things closed and hemostatic.
Make sure he's going to breathe
Try to do
okay.
it fairly
Do you
quickly so
usually
you don't
do
run the
that?
risk of infection.
Yeah, he looks like he's going to quiet right down, so we may, depending on who your mom just tells us, we may be able to transfer him over to
C-section and the risk of infection is pretty low.
just as safety, we'll take him to the NICU to begin with,
See,
okay?
I've got it
And the NICU?
there, and I'll just try this. We've become much more aware of sharp
you later, Mama.
instruments and needles in the last few years.
Looks good.
Peg, you going to take him on to the nursery? Yeah. Okay, irrigation, please. And I irrigate a great deal during these. Irrigation does a couple of things. One, if there are bacteria in here, it presumably dilutes them out a little bit. And it also lets me see if I've got any obvious bleeding sites. Another stitch, please. In the early 1900s, when C-sections were done really just to save the mother's life, one of the major areas in the forceps again, please. One of the major areas of problems were infections in this area.
No.
And what was learned over the years was that if you close this in 2 layers, that you end up with a much stronger incision. Historically, even what they used to do, because these were almost always done with a very sick mom, was they'd actually close the uterus to the abdominal wall and let it drain to the outside. Clearly, as it became a safer procedure with better knowledge of wound healing and infection control and blood banking, I like the first one, blood banking availability, the changes in techniques such as doing it in 2 layers and such has improved it so that it's no longer an operation that's just done to try to help a mom who's actually dying. Joan, Tim, nice baby.
Thank you.
He looks good.
Are you sure?
I am sure. He looked great. This is what's called an embrocating stitch. And what I'm doing is, I've still got uterine muscle here, but what I'm doing is pulling the remainder part of the muscle up over my previous incision and actually making it a stronger incision by just doing it in 2 layers. And the second layer sort of folding in over the first, or embrocating it. I like that stitch. There we go. You can see why this is called a low transverse C-section. This is the kind of cesarean section that if you had a woman who'd had one of these C-sections and she did not have a repeating cause for having a C-section. Joan had a second breech, and so that's why we're doing this. But let's say she had a first baby who delivered by C-section for a breech, and the second one was head down, then you could allow someone with a C-section of this type to deliver vaginally next time, and she would have a 60-70% chance of delivering vaginally the next time. Okay, can I have a little bit more irrigation, please?
They're finishing up, so
Yeah, I wonder if that's from my bladder. No, it's from up here. Great. Okay, we're going to need some more suture here. I've got a bleeder.
Later.
You can have something to drink later on today.
it won't be long.
It won't be long.
That's okay. I'm fine.
Food may be a little while longer,
That's fine.
but we'll get you something to drink. No, ma'am, we don't.
We just gave you one needle.
Okay, I need another stitch, please.
You've only used 2 needles?
And we're just going to sort of clean things up. These drapes here are designed to catch most of the fluid that comes off. And again, she'll have, if things keep going the way they're going now, about 1,000 cc blood loss. And that's normal for a C-section. That's probably something I'm going to have to suture here.
Don't worry, just don't put that on your eye. That's all. Don't want you to do.
This is coming from these little sinuses here that we talked about. It's not really a distinct bleeder, but it's, let me get that one first. And what I'm going to do now is to put individual sutures around the major vessels. This is going to be something called a figure of 8 type suture.
But that's okay.
So
It's inside. It's not back. It's inside out.
2 passes, and then tying it.
Well, we'll just color when the dads have a different color one.
You can see I put my needle way off the field here, and everyone knows it's there, because I'll use this length of suture again. But again, we're quite careful now with where sharps go, particularly needles.
You know what we need is, are these the 3 times that I can use for tubal? Because she's going to do a BTO.
No, they wouldn't do it.
Yeah, that helped that one.
Very nice.
That's nice.
Now down here, yeah.
That looks pretty good. Okay, again, one more view here. This is the bladder. We're not going to close this. There's some people would close that, some people don't. It's really the surgeon's choice at this point. And what we're going to do now is to pick this up and put it back in the abdomen. So we've got that picked up, and we're just going to rotate it and push it. This may be a little uncomfortable. Okay. As I think you've been able to see with this is really entirely a team effort. Particularly delivering a breech. A breech is either made or not the delivery by the skill of the assistant as well as the skill of the primary obstetrician. And you always want to have a good assistant with you when you're doing a breech. And of course, the three most important people here were Joan and Tim and baby Jacob. Babies can be a little bit unstable right after a C-section, particularly because of the temperature changes. Sometimes those babies end up going to the intensive care unit rather than the newborn nursery. They'll put a direct heart rate monitor on the baby so that they can actually count the heartbeats. The baby will also be under a set of lights, and they'll just keep a closer eye on the baby overall. Most of the babies who, after C-section, end up in the ICU are really only there to be monitored for a short time after delivery, and will end up going to the newborn nursery within a few minutes or an hour or so after the delivery. Okay, all right. We're going to close now. This is the rectus muscle, and I'm not pulling this together for anything other than to make sure that the stuff below it stays inside while I'm closing the fascia. This, we're just putting in very loose sutures here, which at this point, which may literally come out in the recovery room. But they're just here to make sure that I don't, for instance, close bladder or bowel up inside the main part of this closure while I do it. Okay. All right, again, and we've got fascia up here. This is the muscle underneath here, and then deep inside there was the uterus where we just were. Okay, Joan, we're almost done here.
Right.
Tim, you did great. Okay, we're going to tie this one.
Suture scissors?
You had staples before?
I think so. Because I have to go have them removed, right?
Suture scissors, please. Again, we're not going to use those.
That sounds good. They weren't comfortable.
They can be a little bit uncomfortable, and a lot of women worry about having them taken out. Since the closure looks the same, and since you're doing so well and anesthesia is so good here, we'll go ahead and take the extra few minutes and close it with a suture that will just resorb. You don't have to have it taken out again. One thing that's always sort of amusing is that when we first start the surgery, the plastic drape that is over the top of the whole abdomen and uterus is very tense and taut. And as you can see here, there are all sorts of wrinkles in that now, and that just is a nice demonstration of how much smaller her abdomen is than it was 45 minutes ago. Okay, we're going to take this plastic from right off the edge, and then I'm going to close her with the subcuticular.
Yeah.
Okay, so what I'm doing is just what's called a subcuticular stitch, and I'm just running this suture right underneath her skin and pulling it together that way. This takes just a little bit longer than closing with staples, which is something I sometimes do as well. But this doesn't have to come out. This will just, as soon as we get done here, we'll just take all the drapes off and roll her from side to side, clean her up, and they've done an epidural, and she'll have a catheter in her back that they can take out if they want to while we're here. And put a clean gown on her and a Band-Aid over this area, and then we'll get her to the recovery room. There. Did it. Yeah, cut that.
It's down the thing.
Okay. We're done. You need help? Okay, thanks.